Hi, my name is Dr. Ed Shahady, and we're here at the Cardiometabolic Risk Summit in Las Vegas, Nevada. And I'm here with Dr. Dan Einhorn from the Scripps Clinic in La Jolla, California. Welcome, welcome.
It's really pleasure to be here.
You know what? It's really been interesting. Sort of seems like the last couple months, some of the issues about diabetes. And by the way, Dr. Einhorn is an endocrinologist, so he really pays attention to all this.
I do.
Sort of a good news, bad news scenario, like with some of the SGLT2 inhibitors. Like one of the good news is with empagliflozin that we've shown some cardiovascular benefit. Really, and as I guess I understand, that's with the recent trials, that's the only drug that's shown that.
First study ever to show that you affect mortality and cardiac outcomes. It's extraordinary. Almost too good to be true, so we have to drill into it.
Sure.
But it's as compelling data as we've ever seen. And it's the first in a class. So we have several medicines that may do the same thing, and that could really change the guidelines.
Right.
And that could change how you treat
How would it change them?
Well, right now, this class of medicines is second or third or fourth on some guidelines. And I think would move it to certainly second after metformin.
Okay.
And the GLP-1s are injectables, have a lot of terrific data, but they might move down a little bit or move in parallel. It'll take a year or two, three, before all the other meds report out. But it's so strong. I mean, the audience that watched this in Stockholm recently was literally oohing and ahhing. And if you know what a group of endocrinologists sounds like, they don't ooh and ah a lot.
They don't?
No, pretty rare.
Doctors in general don't ooh and ah a lot. Okay, so you think it's going to be a class effect? The other SGLT2 inhibitors are probably going to show the same benefit.
Yeah, I think so. But if you take some of the bad news that you mentioned, some of this fracture data.
Yes.
Well, there seems to be different rates of fracture among the three SGLT2s in the United States.
And what are they?
Canagliflozin, EMPA, which you mentioned, and Farxiga.
Yeah.
And so
DAPA.
DAPA, but it's either the particular study population, because it doesn't make sense that they should be different. But we've learned, each molecule is its own life. So I think we'll know soon.
Yeah, really interesting. There's another thing that's come out recently, and one of the recent issues of Diabetes Care addressed this, but euglycemic ketoacidosis. Small numbers, but is this real?
So is this real? In the registration data, which I got to look at for CANA, for InvoCANA, there were 12 out of 18,000 people that got something called ketoacidosis. It turns out that 6 of the 12, half of them, weren't really type 2s at all. They were either LADA or type 1.
Okay. What's LADA?
LADA is a latent autoimmune diabetes of the adults. So they were more type 1-ish, insulin deficient people. And if you looked at the characteristics, they were thinner, they were older, they had diabetes longer, they had worse kidneys. So there were a number of features that made them different. Of the 6, so now it's 6 out of 18,000. Yeah, they did not have the euglycemic DKA. They had a precipitant. They were sick, and they felt sicker when they got the DKA, and the glucose was high. So certainly in that group, it was classic, nothing unusual about it. And most interesting, there was a background rate of DKA in type 2s before the SGLT2s were ever introduced. And so and the background rate arguably is higher. There's a database from Sweden, and there's 4 US insurance carriers. Their rate of DKA was actually a little higher than we've seen in the CANA group. So again, we just have not paid as much attention as we should to the fact that a lot of people who think they're type 2 are not. A lot of type 2s are either LADA or becoming insulin deficient, and a lot and type 1 slip into these research studies. So I think it may still be a reality, but if it is, it's really rare. It's unusual. And so
it's in people who have been stressed out, post-surgery, sepsis, things like that.
So it should be something manageable. For sure would not affect my prescribing decision for this drug.
What about euglycemic? And they're not euglycemic, but they're not 500 or 600 blood sugar. So how do I take care of that word in my thinking?
Yeah. So again, we need to sort out, is it real? Remember that the concept of euglycemic, they're still in the 300s. So it's not that they're normal.
Right.
But the FDA really did not give the granular patient-by-patient data that we've now extracted from the Canna group, and which I understand the other SGLT2s are doing as well, finding similar results. There will be a consensus conference within a month or two that will sort some of this out, and hopefully we'll actually have an answer. But right now, I would prescribe these drugs with confidence, and not only those people. Again, who do you have to worry about? Older, sicker, more frail, worse kidneys. And if you look at the label for the drug, they say you don't want to work with those people anyway. So, so use the drugs on label.
Okay, what about my patient is older, but they're doing well on it? And then all at once they're going to have surgery, or they get septic. Should I, like, preoperatively stop the medication, stop the SGLT2 and not reinstate it until they're cardiometabolically stable?
That's a great question, Ed. So the FDA guidance is not that. The FDA guidance is just be aware that the phenomenon exists. Don't go testing ketones in all these patients. We all have ketones at different times. And just be aware with the stress and with possible precipitants, just be on top of it. But no, there's no suggestion that these drugs will really cause the ketoacidosis in and of themselves.
Okay, very helpful. Go back to the fracture issue, because, we have, not only with the SGLT2s, we have other of our diabetes medications that may be associated with fractures. I guess maybe diabetics have maybe more fractures. But
they do.
What should I do? Should I take, say, certain women that are postmenopausal and not prescribe their medication? What type of caution should I use because of that concern?
Yeah, it's another great question. So both TZDs and our SGLT2s have this fracture warning. And in each case, a fracture that's still rare, and it's not osteoporosis. It's something different, which is what, again, how do we understand it? These are distal fractures. The entire setting is different, but the patients, as you mentioned, those are the patients. Older, frailer, postmenopausal, more likely to be osteoporotic anyway. And you might want to be more thoughtful that it's maybe a riskier strategy. There are some plausible mechanisms whereby both TZDs in a completely different way, SGLT2s, can affect bone quality. But again, distal fractures.
Different. It's not the classic hip fracture that we see with osteoporosis. Okay, very good. Last area, switch a little bit, Dan, but we've also had some sort of exciting news about our blood pressure. And goals. The ADA has changed their goals over time. It used to be 130 over 80, now it's 140 over 90. That's the target. But now the sprint data comes out, and it's always just early release. Seems like that maybe lower is better. You want to comment on that?
Yeah, and I'm proud to say that the American College of Endocrinology never changed its tune. As long as it's true of many metabolic targets, but blood pressure just one. If you can get it lower, well into their normal range, affordably, safely, easily, lower is better. The problem with the history of studies of lower is that often you had drugs with their own side effects and their own difficulties in use, and especially in older, sicker people, it's too late. You can make people worse if you treat bariatric surgery. If you do it late in the game, you can make people much worse in terms of all the outcomes rather than better. And so who you do these things with matters.
So we, ACE, Association of Clinical Endocrinology hasn't changed. You're still 130 over 80.
We are.
88 went up to 140 over 90. So you anticipate that the guideline makers are probably going to drop it down because 70-80% of our diabetics have hypertension. And I still am comfortable with 130 over 80. That's where I grew up. That's what I live with. And that's what a lot of the docs I work with tell me. So you agree with that, and you think this new data, the sprint data, which I guess would be published in a couple months or so, is really going to influence guidelines.
Yes. And remember, that difference is usually one more drug.
Yes.
So you have to be comfortable that one more drug, really pays off, and I would be. One thing I would like to mention that I'm going to talk about during the conference is the newer insulins. It's good news. We just got approval of Degludec, Tracibia, and I think that it, along with Toujeo, which is the U300, they're better, and I think that pegylated lispro coming hopefully the next year or two, better still. I think you have less hypoglycemia with the pegylated, probably less weight gain. And I think they're going to be easier to use. You don't know the problems of, let's say, an insulin until a better one comes along. So, glargine was so much better than NPH. But if you actually look at the kinetics of glargine, it has a peak and a trough. And it doesn't last 24 hours. So the reality is much messier. And once we get to use these new longer insulins, I think we're going to be much happier. Our patients will be able to, I think, experience better control with less hypo.
Excellent. Okay. Wonderful, Dan. Thank you very much for all that information.
Pleasure.